Hello, everyone. This is Dr. Mickey recording the lecture on chapter 31, and it's about the drugs for coagulation disorders and the medications that was known as by lay people. We call that or it's being called by either blood thinners by lay people, or the medical term is the anticoagulants, drugs for coagulation disorders. So the chapter begins with the homeostasis and the clotting process, the internal and external cascade, and the intrinsic and extrinsic cascade or pathways of blood clotting process or formation of blood clot, and the diseases that are in affects the blood clotting, like thromboembolic disorders, which is usually caused by thrombi, blood clot, or emboli, thrombocytopenia, and that's when there is this significant decline or decreased number of platelet counts, and when the patient becomes or individual become at risk for bleeding and tendency to bleed, bleeding disorders like the patients with hemophilia, with a deficiency of factor 8, clotting factor number 8, von Willebrand disease, another bleeding disorder, and the DIC, disseminated intravascular coagulation, and that's when the patient develops the DIC, in which there is a combination of different time frames during the disease process, in which there is bleeding, blood clots, first of all, tiny, small blood clots, multiple blood clots all over the body, blood vessels, and then towards the depletion of the platelet count due to the formation of blood clots, then patients tend to develop the bleeding tendency and the hemorrhage due to the significant depletion of the platelet count. The thrombus formation, in which the blood clot that remains attached to the blood vessel, that's thrombus, that's blood clot formed, which has been contained and formed in the blood vessel, thromboembolus, phlebitis, arterial thrombi or venous thrombi, in which the blood clot has been formed either in the artery or in the vein. So the embolism, which is a bolus of the matter, it can be blood clot, it can be any particle or any substance other than the blood clot, which has been dislodged. Either thrombus, blood clot, can be an air bubble, can be amniotic fluid, the fat, like fat embolism, like during fractures. Fat embolism during the fracture of long bones. Sometimes the fat molecule dislodge and form or become like a form of emboli. Bacteria, cancer cells, foreign substances are going to enter the bloodstream and cause the embolus. So that's the embolism, or the embolus which is can be any form of that. What we just mentioned earlier about the embolism can be a blood clot or any other form of a substance or air bubble or amniotic fluid. So the embolism will cause an ischemia or infarction in the tissue, because that's going to dislodge, is going to obstruct the perfusion, and will cause the ischemic changes to the tissue distal to that obstruction. So beyond the obstruction by the embolism, the tissues will suffer from decreased perfusion, decreased oxygenation, decreased nutrients. That is called ischemic changes, or ischemia, or infarction. The detached thrombus results in embolus, which will travel through a venous system or to the through the venous system to right side of the heart, and it will lodge in the and stay in the pulmonary circulation, and that at this point it becomes the pulmonary embolism, in which that detached thrombus is going to dislodge and travels to the venous through the venous system, superior or inferior vena cava, to the right side of the heart, and it will lodge in the pulmonary circulation, and it will become pulmonary embolism. So there are different types of or medications for coagulation disorders. But first of all, before we get to the drugs and medications as an anticoagulant, to understand and get in depth understanding of what is the embolism, what is the thrombi, what is the clotting or blood clot. So the coagulation problems that affects either arteries or veins are described in this slide. The type of the blood clot, the type of the blood vessel being involved in the blood clot, and what is the characteristics of that specific blood clot has been formed either in the vein or the artery. So, like we have arterial thromboembolism, in which there is a dislodged thrombus, sources usually either from the heart, and most common sites of the obstruction are the lower extremities. Popliteal artery, femoral artery, coronary arteries like an acute MI, cerebral vasculature, blood vessels in the brain. So that's arterial thromboembolism. There's also a venous thromboembolism, in which that the dislodged thrombus, a source of that usually in the lower extremities, blood vessels or veins, that will obstruct the branches of the pulmonary arteries. Was that dislodged from the, like a DVT, deep venous thrombosis, and that dislodgement of that blood clot from the lower extremities, DVT, is going to travel upwards to the lungs to obstruct the branches of the pulmonary artery and lead to pulmonary embolism. Air embolism, amniotic fluid embolism, bacterial embolism, fat embolism, and foreign matter. And it can be small particle fiber introduced into the during the trauma, or through sometimes IV or intraarterial line insertion or removal. Sometimes during the removal of the CVL or the CVE, the central line, TLC or central line removal, sometimes a little particle of the catheter remains in the bloodstream, and that will lead to the embolism. So that's why it's critical that when we remove the central line, that we get the full length of the central line being removed, as compared to the prior to the insertion or during the insertion time that we have recorded length of the central line or the TLC catheter. So this slide shows the obstruction of the different types of arteries and blood vessels, a resultant effect on the perfusion. Peripheral vascular disease, PVD. So we have different forms of the PVD. The first one is called thromboangiitis obliterans, or what is known as Berger's disease. Thromboangiitis obliterans or Berger's disease, and usually it occurs mainly in young men who smokes. It's an inflammatory disease of peripheral arteries, resulting in the formation of the non-atherosclerotic lesions, like in the tibia, ulna, palmar arteries, and the palms. So there's pathophysiology unknown pathophysiology for this disease, but there's an evidence of the T cell activation and autoimmunity and inflammation, in which thrombi and vasospasm characterizes this disease. So the drug obliterates the small and medium-sized arteries, causes manifestations of pain, tenderness, and hair loss in the affected area. Symptoms are caused by the very slow, sluggish blood flow. Perfusion is extremely reduced or declining, decreased. The blood flow and perfusion has been decreased and sluggish and slow. It can sometimes, often lead to gangrenous lesions due to that slow or sluggish blood flow to the affected tissues. Now, the Raynaud's phenomena or Raynaud's disease, which is the episodic vasospasm in the arteries and arterioles of the fingers, less commonly the toes. Now, Raynaud's disease is a primary vasospastic disorder of unknown origin. Now, the pathophysiology that there is an imbalance in the endothelium-derived vasodilators, which is the nitric oxide. So the nitric oxide is a vasodilator. So there is an imbalance in the endothelial-derived vasodilator, which is nitric oxide, with the endothelin-1, which is a vasoconstrictor. So nitric oxide vasodilator, endothelin-1 is vasoconstrictor. So we have, in other words, that that imbalance between these two, nitric oxide and the endothelin-1, creates the problem of the vasospasm and the spastic or the vasoconstriction of the arterioles and the arteries. In other words, that in this disease, the pathophysiologist says that there is more of the endothelin-1 compared to the nitric oxide. So the collagen vascular disease like scleroderma, smoking, pulmonary hypertension, myxedema, environmental factors, all these can be an etiology and causing factors or resultant causation of this disease. Cold and prolonged exposure to vibrating machinery. People who work on vibrating machinery, repetitive motion of the working on certain machines sometimes result in this vasospasm in the arteries and arterioles and what's called Raynaud's disease. So Raynaud's phenomenon is secondary to other systemic diseases or conditions. So as we have mentioned, some of these conditions and diseases that may result in Raynaud's disease, collagen vascular disease, which is scleroderma, smoking, pulmonary hypertension, myxedema, and environmental factors like cold temperatures, prolonged exposure to vibrating machinery. So what precipitates the disease, certain things that may precipitate the signs and symptoms and make it more exacerbation of the disease process. So the disease may be precipitated by cold exposure to cold temperatures, emotional stress, and smoking. Peripheral artery disease, or PAD, is most of the time is asymptomatic in its early stages. So the evaluation of the PAD requires a careful history and physical examination that focus on finding evidence of atherosclerotic disease, like if there's any bruit on auscultation, for example. Measuring the ankle and brachial index, the difference between brachial blood pressure and the ankle blood pressure. Measuring the blood flow using the Doppler ultrasound. Most of the PAD affects the lower extremity ischemia, lower extremity ischemia, which will result from the arterial obstruction of the PAD, which usually most gradual and sometimes even acute in the episode. Vitamin K deficiency. So we need vitamin K. It's necessary for the synthesis and regulation of the prothrombin and prothrombin factors like factors 2, 7, 10, and 11, and the proteins. We have two different types of proteins, which is anticoagulants, or considered as anticoagulants, which is protein C and protein S. These are very important for the process of blood clot formation or coagulation process. The liver also is important for the blood, for the producing and synthesizing all these the clotting factors. So it's responsible for the homeostatic disorders, in which that it's responsible for the synthesis of the clotting factors. So patients with liver disease, they will have a defects in coagulation and a defect in the number and the quantity and the function of the platelet count, platelet cells. So clotting factors, before we get to the VTE, the clotting factors, we have two different pathways, like intrinsic and extrinsic pathways. So the clotting factors in which that the blood clot, which is like a meshwork of protein, fibrin, that stabilizes the platelet plug. So these, this meshwork protein strand that stabilizes the platelet plug, these strands, they are made by the clotting system, which is the coagulation system, by the intrinsic pathway and extrinsic pathway. So the intrinsic pathway, which is which will be activated when the factor number 12 contracts the subendothelial substances exposed by vascular injury. Now, the extrinsic pathways that will be activated when the tissue thromboplastin is released by the damaged endothelial cells. This might sound like an advanced pathophysiology, but at least just to for the scope of this class is just to know that there is an intrinsic and extrinsic pathways for the clotting, blood clot formation. And for the homeostasis to occur, there is a blood clot will be formed, and blood also clot that's going to lyse or to disintegrate. So the lysis of blood clot, which is called a fibrinolytic system, responsible for the degradation of the blood clot. So the plasminogen and plasmin, they are part of this fibrinolytic system, refers to the fibrinolytic system, the fibrin degradation products as well. So we have like plasminogen, plasmin, which is part of the lysis of blood clots. So the blood clot will form, and the body is going to be having also the ability to disintegrate this blood clot after it's been formed. So the venous thromboembolism means there is blood clot, thrombosis has been formed, thrombus. What are the factors that will promote the formation of blood clots? There is a rule or a phenomena called triad, which stands on three arms. The three arms are venous stasis, endothelial damage, and hypercoagulability of the blood. So the pulmonary embolism is the major risk of thrombus immobilization. So when the blood clot dislodges, or the dislodgement of the blood clot travels to the either heart, brain, or lungs. And mostly the lungs is the most dangerous and most fatal is the pulmonary embolism. The most risk or major risk of thrombus immobilization is the pulmonary embolism. There is also thrombophlebitis, which is associated with inflammation, with clot, but with inflammation. Phlebothrombosis, which is a thrombus that has been formed without inflammation. So the three main arms of the triad that govern or this rule or this phenomenon or the three main reasons why patients will develop blood clot, either because there is a venous stasis, there is a stagnation of blood, patient is being pulled either in the blood vessels or in the heart, sometimes like atrial fibrillation, a form of that, because there is a pulling of blood, stagnation of blood in the atria. Endothelial damage, that's an injury to the endothelium of blood vessels, the inner lining of the blood vessels, and damage to that blood vessel can result in easy forming of blood clot on the damaged endothelium. Hypercoagulation, also that's the third arm of this triad, in which that would lead to the thrombus formation. So these are the three main reasons, and there are many factors under each one that will promote the blood clot formation. Like when we say venous stasis, for example, normal venous blood flow, the flow of the blood in the veins, the normal flow of the blood in the veins depends on the action of muscles in the extremities and the functional adequacy of the venous valves. There are valves in the veins, and they are one-way valve allowing for the blood return towards the heart. So by gravity, enters, and then valves supposed to allow the blood to return to the heart one way. So which allow unidirectional flow. Unidirectional flow, which is being one-way valve. So venous stasis occurs when the valves or these valves become dysfunctional or the muscles of the extremities are inactive. So the venous stasis or the stagnant pooling of the blood more frequently will occur in people who are obese, pregnancy, or who have a chronic heart failure, chronic atrial fibrillation. So people who are obese, pregnant, have chronic heart failure or atrial fibrillation, they are more risk for the stagnation of blood and blood pooling, pooling of the blood, and that precipitate for blood clot to form. Or sometimes people who have been traveling on long trips without regular exercise of the lower extremities. And that's where the blood's going to be cooled and lead to blood thrombus, which is a DVT, deep vein thrombosis. Or people who have prolonged surgical procedure or are immobile for long periods. So patients who are bedridden with no PT, no activity, no ambulation, no assistance, and to be out of bed, and they are immobile and they are, due to this immobility, they are in bed for long periods of time, like spinal cord injuries, fractured hip, or paralysis. They are prone at risk for the venous stasis and blood clot formation. So the risk for the thromboembolism or the VTE, due to this venous stasis, it can will have many risk factors: advanced age, atrial fibrillation, CHF, obesity, orthopedic surgery like the surgical procedure of the lower extremities or hip fractures, pregnancy and postpartum period, prolonged immobility, like in bed rest, fractured leg or hip, long trips without adequate exercise, spinal cord injury or limb paralysis, patients who have developed stroke or sustained stroke, or varicose veins. The second one is endothelial damage, which is the damage to the endothelium of the vein, may be caused by direct or indirect factors. Direct factors like surgery, intravascular catheterization, trauma, fracture, burns. Indirect factors like chemotherapy, vasculitis, sepsis, diabetes. Now, the damaged endothelium stimulates the platelet activation and which will initiate the coagulation cascade to result or lead to blood clot formation. So this results in a decreased fibrinolytic capabilities and predispose the patient to thrombus development and form the blood clots. So we say fibrinolytic capabilities means the ability to disintegrate and dissolve the blood clot, naturally intrinsic natural pathway. So there is a decreased fibrinolytic capabilities that will predispose the patient to form the blood clot. Endothelial damage sometimes result from the abdominal and pelvic surgery, like gynecologic or urology surgery, or fractures of the pelvis, like hip fractures, leg fractures, or history of previous VTE, venous thromboembolism. Patients who had sustained or had an indwelling catheter or peripheral IV catheter or central vein catheter, that's another risk for blood clot to form. Either superficial, SVT, thromboembolism, or the DVT, deep vein thromboembolism. Sometimes intravenous drug abuse, trauma, another factor, risk factor for the endothelial damage. The third arm of this record triad is the hypercoagulability of the blood, which occurs in many hematologic disorders, particularly would be like polycythemia, 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 in which there is an extremely high red blood cells and hemoglobin levels. Severe, sometimes also the hypercoagulability of the blood. Hypercoagulation results from the severe anemias, malignancies, nephrotic syndrome, which affects the kidneys, or elevated lipoprotein, or elevated clotting factor number 8, protein C deficiency, or protein S deficiency. So a patient with sepsis is predisposed to hypercoagulability due to the endotoxins that are released from the bacteria or from the microorganism. So the patients who have sustained the sepsis, they are predisposed to the hypercoagulation due to the effect of the endotoxins that has been released from the bacteria and has and its effect on the coagulation cascade and the resultant blood clot formation. The women of a childbearing age who have who are usually take the oral contraceptives, which is estrogen-based oral contraceptives, or post-menopausal women who use the oral hormone replacement therapy, HRTs, the oral hormone replacement therapy, which can be estrogen or estrogen plus progesterone. They also at increased risk for VTE, or even women who use the oral contraceptives and tobacco, they have like a double risk because of the vasoconstricting effect of nicotine from the tobacco. Now, the smoking causes a hypercoagulability by increasing the plasma fibrinogen and homocysteine levels and activating the intrinsic coagulation pathway. So smoking causes hypercoagulability by increasing the plasma fibrinogen and homocysteine levels, and which will activate the intrinsic coagulation pathways. Many disorder factors that may predispose patients to have the hypercoagulability of the blood and high tendency to develop the blood clot, like the antiphospholipid antibody syndrome, cigarette smoking, dehydration or malnutrition, elevated clotting factor number 8, or lipoprotein. The people or patients who live at high altitude, higher than 10,000 feet above the sea level, they're at high risk to develop the polycythemia and the hypercoagulation. People who live in high altitudes, or patients or individuals who take the women who receive the oral hormone replacement therapy, especially postmenopausal women who would receive the oral hormone replacement therapy, especially estrogen plus progesterone, or patients with homocystinemia, which is the high level of the homocysteine. Patients with malignancies, especially breast cancer, brain cancer, hepatic, pancreatic, GI, so malignancies in general. Nephrotic syndrome. Other diseases may predispose to the hypercoagulation include we said polycythemia, oral contraceptives, protein S or C deficiency, sepsis, severe anemia. So these are the lab tests that measure the coagulation. So these are the tests used to for diagnosing and treating coagulation disorders. So we have the activated clotting time, prothrombin time, PT, international normalized ratio, INR. It's always PT INR goes together. Thrombin time, and APTT or PTT is the same, which is activated partial thromboplastic time, activated partial thromboplastin time, liver function test, bleeding time, and then we have platelet count, which is PLT. So the prevention and prophylaxis of VTE, venous thromboembolism, in adult health too, we'll cover the in-depth manifestations and treatment and the nursing care of patients with VTE, either a deep vein thrombosis or the superficial vein thrombosis, DVT or SVT. So the VTE prophylaxis in surgical patients is a core measure of high-quality healthcare in high-risk hospitalized surgical patients. Every single hospital is supposed to present and prove and present that there is a protocol that will prevent the VTE for all admissions, for all patients being admitted to the hospital. There should be a protocol that should be applied and integrated to the system to prevent the VTE or thromboses for all patients. So in addition, it's recommended that hospitals have a formal hospital-wide thrombo prophylaxis policy. It's called VTE prophylaxis policy that actively addresses the VTE prevention on admission for all adult patients. So in patients at risk for VTE, yearly and aggressive mobilization is a preventive measure. Because the bed rest, so we reposition the patient every 2 hours, flex and extend the feet, knees, and hips every 2 to 4 hours while awake, out of bed, ambulation to chair, or transfer a patient out of bed to chair, walking or ambulation 4 to 6 times daily. These are great yearly and aggressive mobilization steps to prevent the VTE or thromboses. The graduated compression stockings, or what is called the TED stockings, thromboembolic deterrent, or TED stockings, which is often used with anticoagulation and should be fit and work correctly. The size, the application, the timing. So no wrinkles. So if the VT already exists, it's not recommended. It's preventive, so it's for health promotion, which is, in other words, to prevent the VTE. But once the VTE has formed, resulted, then the TED stocking is no longer effective. Also, we can apply what is called the sequential compression devices, SCDs, or what is called the intermittent pneumatic compression devices, IPCs. That would, there's an increased venous return, which is an external pressure from electric pump, which will inflate the sleeve or the boots to compress the calf or thigh and or foot and ankle. So on and off, inflation, deflation is going to create like a stimulation of the blood flow. You can use with graduated compression stockings or TED stockings. Should fit and apply correctly. And it can be, we can apply it continuously except for bathing or an assessment or for ambulation that shouldn't be applied or should be taken off. The lab testing for or blood tests for coagulation. So we have a INR, which always goes with a PT, and we have an APTT. So the two main forms of blood clots, of blood testing for coagulation. So the acute intervention, since effective anticoagulation is essential, we should review with the patient any medications, vitamins, minerals, dietary, and herbal supplements being taken that may interfere with the anticoagulation therapy. Even over-the-counter medications, herbal medications, supplements, sometimes they do interact with or interfere with the coagulation therapy. So should be reviewed with the patient, patient with the PCP to make sure that, there is no any harm or increase or decrease effectiveness of the anticoagulant therapy. So depending on the anticoagulant therapy being prescribed, we have to monitor either the INR, like PT-INR, APTT, or ACT, or anti-factor XA levels, CBC, creatinine, factor 10 levels, hemoglobin, hematocrit, platelet count, liver enzymes. All these are common for patients who at risk or of blood clot or patients who receiving the anticoagulant therapy. So we will monitor the platelet count for patients receiving the unfractioned heparin or low molecular weight heparin. This is for the heparin-induced thrombocytopenia. And we'll talk more, we'll discuss in the upcoming slides about the HIT, H-I-T, heparin-induced thrombocytopenia. And we kind of would titrate the doses of the unfractioned heparin, warfarin sodium or coumadin, or direct thrombin inhibitors based on the results of the clotting studies or factors or values based on, or as we follow the prescriber's established parameters. So the anticoagulants, we have different groups of anticoagulants. The first one is the vitamin K antagonist. So the anticoagulants, it's a VTE prophylaxis. It will prevent blood clot formation. Even with the existing VTE, it will prevent the no clot formation or the spread of the clot that has been formed or immobilization of the clot has been formed. So these are the four major groups of blood anticoagulants. The first one is the vitamin K antagonist. Number two, which is indirect thrombin inhibitors. Number three is the direct thrombin inhibitors, and four, factor XA inhibitors. So the use of the aspirin alone for the VTE thromboprophylaxis is not recommended for any patient group, given its too many side effects and effectiveness or decreased effectiveness. It's not recommended for the prevention of the VTE thromboprophylaxis. Another fact about the anticoagulant therapy is that the anticoagulant medication, it does not dissolve the blood clot. It will prevent the formation of a new blood clot. However, the lysis or degradation or the dissolution of the of the clot begins spontaneously through the body's intrinsic fibrinolytic system. The body itself has a spontaneous fibrinolytic system that is going to dissolve the blood clot. So we have different anticoagulant therapies according to its mechanism of action. Anticoagulants that will inhibit the clotting factors and eventually will prevent thrombus growth. Antiplatelet, it will inhibit platelet action and prevent thrombin growth. Thrombolytics, these are the medications that's going to dissolve the existing blood clot or thrombus. The hemostatics, they inhibit the fibrinolysis. In other words, it will promote clot stability. Because fibrinolysis is the process of the degradation, dissolution of the blood clot, and the breakdown of the blood clot. So hemostatics, which will inhibit this fibrinolysis, it eventually is going to promote the clot stability and maintain the blood clot stability. So the first prototype drug for the anticoagulant is going to be heparin as a parenteral anticoagulant. Either it's given IV, intravenous, or sub-Q. So heparin can be used as a both prophylactic and for treatment indications. So it is used at low doses to prevent thromboembolic events, blood clots, arising from open heart and vascular surgery, dialysis procedures, or in patients with unstable angina or in the acute stages of acute MI. It is also used at higher doses to treat conditions in which immediate anticoagulation is necessary, such as confirmed DVT or confirmed pulmonary embolism. So the dosing of the heparin parenteral is highly variable depending upon the indication and of the disease and or disorder, and is often based on a weight-based nomogram and the PT value. So we have like a sliding scale, and we're going to titrate the heparin drip based on the APTT value, activated partial thromboplastin time values. So that's what determines the heparin doses or rate of infusion. So the infusion rate of the heparin is going to be determined by the sliding scale using that protocol. You know, when it's the PTT from 2 is going to either stay and maintain the same or increase or decrease based on these values. So adjustment of the dosage of the heparin rate is going to be based on the APTT values, which will be frequently done either for every 6 hours or 12 hours, depends on the case. So the heparin is we said administered usually as an via IV or intravenously or sub-Q. The adverse effects, the most important one is the bleeding. The second is the HIT, which is heparin-induced thrombocytopenia, which is a serious complication, which occurs in about 30% of the patients who take the heparin IV. And usually appears after 5 to 10 days of therapy, in which that you will find out that the patient's platelet count, PLTs count, will be significantly very low, less than 140,000, and that's an indication that has been reduced or declined or decreased count of the platelet due to the heparin therapy. So it's called HIT hit. Now, the treatment for the overdose, anytime you find that the patient has received an overdose of heparin, heparin toxicity, so the antidote is going to be the protamine sulfate to be administered intravenously, 1 milligram for every 100 units of heparin. So that kind of, it will neutralize the patient's anticoagulant activity. Now, the vitamin K antagonists, which is warfarin and sodium. So the warfarin and sodium is a vitamin K antagonist, which will inhibit the vitamin K dependent coagulation factors 2, 7, 9, and 10. In addition to the anticoagulant proteins type C and S. The warfarin and sodium, or the Coumadin, is usually prescribed for long-term or extended anticoagulation purposes, months or years. It takes about 48 to 72 hours to be effective. And sometimes they will overlap with parenteral anticoagulant like heparin for about 5 days. I will explain more about this concept in class. So for the warfarin and sodium, we have to monitor for the PT-INR. And patients who may develop the warfarin sodium or Coumadin overdose or toxicity, the antidote for this is going to be vitamin K. So patients on Coumadin, they should avoid the vitamin K in dietary recommendations, or food that is high in vitamin K should be avoided because that will alter the INR values. Like the green leafy vegetables, it's high in vitamin K, should be consumed moderately, or should be careful not to consume too much of the green leafy vegetables, because it's the high content of vitamin K, which may alter the INR values. The third group of meds, which is the direct thrombin inhibitors, which includes the Angimax, the Ergetroban, the Dicerudin, or the Dabigatran, which is the Prodexa. The Prodexa, which is the Dabigatran, That's only one available orally PO tablet. So the only within this group, the direct thrombin inhibitors, the only PO tablet is the dabigatran, which is the Pradaxa. The indications would be for patients with or at risk for the HIT, which is heparin-induced thrombocytopenia, having a percutaneous coronary interventions, PCI, like angioplasty, balloon angioplasty, and cardiac, catheterization procedures that will involve the percutaneous coronary interventions. So we have to monitor the APTT and or sometimes the ACT. There is no antidote for these meds. The disirudin, which is the Eprivasc, it's usually given subcutaneously 15 minutes pre-op before the hip surgery, which is like a prophylaxis of the DVT. However, the Pradaxa, which is the dabigatran, which is the PO, the tablet, that's the newest drug indicated to reduce the risk of stroke and embolism in patients with atrial fibrillation and treatment of a DVT and pulmonary embolism for patients who have been treated with anticoagulants for about 5 up to 10 days. We can put them on Pradaxa after that. Direct thrombin inhibitors, dabigatran, which is the oral Pradaxa, which is the oral tablet. So we talk about the indications for that, which is like a VTE prevention after elective joint replacement for stroke, also for stroke prevention and non-valvular atrial fibrillation, or as treatment of a VTE. So these are the indications for Pradaxa, like the oral. When we put them on oral medication, oral Pradaxa, that's can be indicated for patients with a VTE prevention after elective joint replacement, like hip fracture and joint replacement, or even knee replacement. For patients who had sustained stroke prevention, and patients with AFib, or even treatment of, for patients who had developed a VTE. The advantage of the Pradaxa over the warfarin, why the Pradaxa is better than the warfarin sodium Coumadin, because of the rapid onset. There is no any requirement for monitoring the blood lab values like the PT-INR. There is a few drug-food interactions. They don't have to commit or not to consume certain types of food because of the interaction between the drug like Coumadin, warfarin, sodium, or Coumadin or warfarin, sodium, and food. So a few drug-food interactions and decreased risk of bleeding compared to the warfarin sodium. So this is the advantage of the Pradaxa. Now, the factor XA inhibitors, which is the fourth group of anticoagulant medications, which inhibits the factor XA, which result in rapid anticoagulation, anticoagulation as blood thinners. So it's a VTE. So in terms of the indications, it's usually indicated to prevent like prophylaxis of VTE and the treatment of the VTE, venous thromboembolism, like deviant thrombosis, pulmonary embolism, UTMI, and similar conditions. So we have the Orextra, which is the Fondaparinux sub-Q injection. It's contraindicated with severe renal disease. So patients with renal kidney issues or dysfunctions or renal failure, they should not receive the Fundap-Renox. So the Fundap-Renox or Arextra should not be prescribed for patients with severe renal disease. Now we have the newest or the new drugs like and more safer drugs like the Xarelto, Eliquis, Xarelto and Eliquis. They're oral tablets, oral prescriptions, or oral formulation of the anticoagulant drugs, medications. So compared to the Coumadin or Pharm, they are way better than the Coumadin because there is no requirement to monitor the blood labs like PTINR or PTT. So monitoring not required compared to, that's why it's more safer drugs than the Coumadin or Pharm, and it's more convenient. But the problem with these no drugs or no drugs, they are very expensive. The 30 pills for example, the Xarelto goes up to about $500 up to $600 for a month supply. Drug supply of Xarelto can cost up to $600. And the problem is that some of the insurance companies would not cover the cost of the cost of the drug. So what would be the treatment for an emergency bleeding due to warfarin or Coumadin overdose? So it's an IV vitamin K, which is required, and not the oral route. We have to give, it's emergency with Coumadin or warfarin sodium overdose. We have to give the IV vitamin K, not the oral vitamin K. So to treat the anticoagulant overdose, you will treat with the antidote when the assessment findings reveal that the patient had an active bleeding. So don't treat until you find out that there is an active bleeding due to the overdose of Coumadin or warfarin sodium, like there is an external bleeding, there's a hematuria, or there is signs of internal bleeding. Internal bleeding will be indicated by symptoms like low blood pressure and high pulse, tachycardia. That's an indication there is an internal bleeding. That's when you would treat patient with an antidote which is IV vitamin K for internal bleeding due to the overdose from the Coumadin, warfarin sodium. Peripheral vascular disease, PVD. So which indicates the disorders that change the natural blood flow and perfusion to the tissues of the lower extremities through the arteries and veins of peripheral circulation. And most of the time when we say PVD, we imply PAD. So peripheral vascular disease all implies that it's mostly arterial in nature rather than venous involvement. So the PVD, peripheral vascular disease, affects the legs much more frequently than the arms. So the pathophysiology of the PAD is a result of systemic atherosclerosis. It's a chronic condition, usually. It's either partial or which would result in a partial or total arterial occlusion. So the obstruction, the occlusion, either is partial or total. And the PAD in the lower extremity is called LEAD, L-E-A-D, which is lower extremity arterial disease. Lower extremity arterial disease, which is one of the manifestations of systemic atherosclerosis. LEAD, lead. And it's associated with a high risk of cardiovascular morbidity and mortality, functional impairment, and decreased quality of life. What would be the early diagnoses of lead disease? It allows a more rapid initiation of lifestyle changes and specific treatment with better diagnoses. So the lead, which is the lower extremity arterial disease, or the PAD, or lower extremity disease, it increases the general cardiovascular risk. Patients with this disease, are having like a five-fold or even six-fold high risk of morbidity or mortality than from other atherosclerotic causes, such as like coronary artery disease or stroke. So the also more in adult health too about the obstruction about affecting the PAD, that the obstruction is either inflow or outflow. The risk factors for PAD includes atherosclerosis, hypertension, hyperlipidemia, diabetes mellitus, cigarette smoking, obesity, familial predisposition or familial factors, advanced age. And this disease affects about like 10 to 12 million people in the USA. Most of them are older than 65 years old. The African American are more affected than any other group because they have the many risk factors like hypertension, diabetes, mellitus. The classic symptoms of the peripheral arterial disease, it's a chronic disease. The four main stages that will be also discussed in adult health too, including which is like asymptomatic stage 1, stage 2, claudication, stage 3, rest pain, stage 4, necrosis or gangrene, and in which that most patients are not diagnosed until they develop the leg pain, which is the intermittent claudication. So when we see intermittent claudication, which is a classic symptom of the PAD, it's derived from the word meaning to limp, ischemic muscle ache or pain that is precipitated by a constant level of exercise. Usually, the intermittent claudication resolves within 10 minutes or less when the patient rests after walking or ambulation. And the symptoms will be reproducible with exercise. So it's kind of on and off. Patient walks for 1 or 2 blocks, then they have severe lower extremities pain, intermittent claudication, and they stop. Pain resolve or subside. And then they resume walking. They will complain of the same pain. Then, then once they stop walking, then pain will subside. And that's kind of like a cycle on and off. That's why it's called intermittent claudication. Patient will feel that paresthesia, it's like a tingling sensation with painful sensation. Also, patient will experience other symptoms like thin, shiny, and taut skin, loss of hair on lower extremities, that's from decreased perfusion, diminished absence, pedal, popliteal, or even femoral pulses, pedal pulses, tibialis pulses. Also, all these peripheral pulses will be diminished or sometimes at some point absent. Pallor, hyperemia, and the rest pain. That's when which is a sign that of an advanced disease. So when the patient develops that breast pain, that's the sign of advanced disease and occurs in the forefoot, on the toes, or in the heels, and is usually aggravated by limb elevation. So when they elevate the limb, that's going to, the pain will become severe. So it becomes severe when the patient elevates the limb. So limb elevation will aggravate the pain in the limb. Burning sensation, numbness sensation, paresthesia. And that usually results from the insufficient blood flow to the lower extremities. And occurs mostly or more often at nighttime. So to relieve that pain, patients usually they have to keep the limb in a dependent position, which in other words is lower than the heart level, so that the pain level will be relieved or reduced. The complications of peripheral arterial disease, it may result in atrophy of the skin underlying muscles, delayed healing, wound infection, tissue necrosis, arterial ulcers. And these are examples of the difference between arterial ulcers and the venous ulcers. And the arterial ulcers are more painful and develop usually on the toes, or even between the toes or the upper aspect of the foot. And with prolonged occlusion, that can result in gangrene. Or become gangrenous. So the arterial ulcers, typically, the ulcer or the ulceration is like rounded, well circumscribed and small, punched out, and well-defined borders. However, compared to the venous ulcers, they are more weepy, like there's a lot of secretions coming out. It's more beefy and there's a lot of reddish color, and it's not well defined. It doesn't have a well-defined borders, so it's not like rounded, and that's and it's usually above the ankle, the venous ulcers. Risk factors for PAD would include smoking, tobacco cessation. Risk factor also and modification. So we can include modifying these risk factors. So in terms of like risk factor is smoking, the modification would be like tobacco cessation, to stop smoking. If the risk factor is aggressive treatment of hyperlipidemia, then we will initiate or establish an aggressive treatment for the hyperlipidemia, like a diet, statins, put the patient on lipid lowering medications like statins and dietary modifications. If that's a hypertension and diabetes mellitus, when we have to manage and treat these conditions, chronic diseases, so it will prevent the long-term complication of PAG. The patients with high blood pressure, hypertension, we we have to maintain the blood pressure lower than 130/85. Reducing the sodium diet, using what is called a DASH diet, and we'll cover this DASH diet, DASH diet, in adult health too. We can, in patients who are diabetic on diabetes mellitus, we can maintain their hemoglobin A1C less than 7.0%. Now, this is the risk factor modifications. What about the drug therapy, medications to treat patients with PAD? So we have antiplatelet agents and drugs prescribed for the intermittent claudication and the severe painful sensation of lower extremities, especially with exercise or activity. The anticoagulant therapy, which is like aspirin, ticlopidine or ticlid, and then clopidogrel, or which is Plavix. So the antiplatelet drugs, we said, includes the aspirin, and adenosine diphosphate ADP receptor blockers, which is like a protein 2B, 3A receptor antagonist, and drugs for the intermittent claudication. So the protab drug for the anticoagulant or antiplatelet group, or the class of medications called ADP receptor blockers, Plavix or clopidogrel, is usually indicated for reducing the rate of the acute MI or stroke in patients with acute ST elevated MI, or reducing the rate of acute MI or stroke in patients with unstable angina or non-ST elevated MI. Also, the clopidogrel Plavix may also be given off-label use, so off-label to prevent thrombi formation in patients with coronary artery stents. So status post, a placement of the coronary artery stent, we can prescribe clopidogrel, and also to prevent post-operative DVTs. So post-op, after like hip surgery, to prevent the DVT, clopidogrel is a good preventive drug to prevent the DVT. So unless otherwise contraindicated, clopidogrel sometimes is prescribed in conjunction with aspirin, like placement of a stent, cardiac or coronary stent. Patient will be on clopidogrel and aspirin concurrently for 6 months to prevent the thrombosis or blood clot to form on the stent. So the clopidogrel as a anticoagulant drug, it prolongs bleeding, prolongs the bleeding time by inhibiting the platelet aggregation. So it's the antiplatelet aggregating drug. So it will inhibit the platelet aggregation, so it will prolong the bleeding, or in other words, it will directly inhibit the ADP binding to its receptor. And this binding is irreversible, and the platelet will be affected for the remainder of its lifespan. So that's exact mechanism, how the mechanism of action of this clopidogrel as an anticoagulant drug. So the tablet should not be crushed or split. Discontinue drug at least 5 days prior to surgery, so it will prevent bleeding during surgery, during or intra or post-op. So the fibrinolysis from fibrin. Lysis means dissolution or degradation or breakdown. So the breakdown of the blood clot, fibrinolysis, which is the clot removal. The intrinsically, our body has the ability to maintain the homeostasis between blood clots and the formation and the dissolution breakdown of these blood clots. So blood clot formation, thrombosis, and fibrinolysis. That's the homeostasis. That's in which that our body is not going to maintain or develop the blood clotting. So the fibrinolysis, it's the clot removal, which starts within like 24 to 48 hours of the clot formation. The process is usually initiated by the release of the TPA, the tissue plasminogen activator, in which that the TPA is going to, tissue plasminogen activator is going to convert the plasminogen into plasmin. And that's how the tissue plasminogen activator, the TPA, is going to dissolve and break down this blood clot. So this is the group of medications, fibrinolytic meds or thrombolytic medications. These are the meds that are going to dissolve and break down the blood clot, in which that the plasmin will digest the fibrin strands and eventually is going to resume or restore the circulation, because the obstruction has been resolved and the blood clot has been dissolved and broken down to small fragments. So the thrombolytics, which are the medications are going to dissolve the blood clot, or fibrinolytics, the same thing as a thrombolytics. The primary use is to treat the acute myocardial infarction, deep vein thrombosis, to treat the cerebrovascular accident, which is a stroke or CVA, pulmonary embolism or arterial thrombosis, and to clear the IV catheters if there is any tiny small superficial blood clots or like SVTs. So the mechanism of action is to convert the plasminogen to plasmin, which will digest the fibrin and dissolves the clot. And the adverse effect is, will be obviously the abnormal bleeding. So it should be contraindicated in patients with bleeding tendencies or bleeding disorders, patients who had underwent like a recent trauma, or underwent a surgical procedure. They should not receive any thrombolytic medication. So the prototype drug for the thrombolytics or fibrinolytics medication is the alteplase or a TPA. It's a TPA, tissue plasminogen activator. Alteplase, activase, ritaplase. There are too many generic drugs, in this group. So the alteplase must be given within 12 hours of onset of symptoms of the acute MI and within 3 hours of thrombosis or thrombotic stroke for maximum effectiveness. So for this drug to result in maximum effectiveness, it should be administered within a specific time frame. Like for example, for the acute MI, within 12 hours. It can be given still effective within 12 hours after the acute MI, but if the most effectiveness of after the acute MI should be given within 6 hours, but it's still even within 12 hours will be effective. Now, however, for patients who have sustained or had the thrombotic stroke, they should receive it no longer than or later than 3.5 hours from the onset of the thrombotic stroke. So within 3 up to max of like 3.5 hours to administer the TPA for patients post thrombotic stroke. So again, it's 12 hours, within 12 hours for acute MI and 3.5 hours for thrombotic stroke. And this drug is going to take care of the blood clot and will dissolve it, break it down, small fragments, and it will dissolve the blood clot. That's a TPA. And we have different types of thrombolytic drugs like streptokinase, alteplase, TPA, tenecteplase, or ritaplase. And there is, for each one, we have a trade name, description, the source, the mechanism of action, the side effects, and what is the half-life, what is the dosage administration. I'm not requiring or requesting or asking that you know all of these information or all of this, this specific, specifics about each one of these drugs, but at least just to understand the concept of what is TPA, what it does, or what's the mechanism of action, and what are the indications for a TPA. The hemostatics, which is medications, drugs used to promote the formation of clot and to sustain and prolong the clot and to maintain the clot that has been formed. So it will prevent the fibrin from dissolving. So the primary use is to promote the formation of blood clot by preventing and treating the excessive bleeding from surgical sites. And the first type of drug for this one is the aminocaproic acid, which is Anicar. And there will be a few questions in which I will explain more about the aminocaproic acid as we answer the questions in class, and the role of the nurse and or for patients who take the hemostatics is that to monitor for the clotting, to administer the intravenous medication, like medication through the IV intravenously, and to monitor the site closely and assess for any reddish brown color of the urine, which is a sign of myopathy or myoglobinuria, which is a sign of in other words, it's the sign of breakdown of the muscle tissue. So we have to teach the patient to report symptoms of clotting or bleeding and not to take other anticoagulants like aspirin while taking the hemostatic medications. Now, the thrombocytopenia, which is the platelet count that has been reduced or reduction of platelet count less than 150,000. So anytime you have a patient with platelet count that is less than 140,000 or 150,000, that is called this is called thrombocytopenia. In which with this specific number, there are 3 other sub-classifications in terms of, like, for example, patients with platelet count less than 50,000. You will definitely see there is a hemorrhage bleeding from minor trauma. When the patient's platelet count is less than 15,000, then you will anticipate spontaneous bleeding. However, when the patient's platelet count is less than 10,000, patient will experience severe bleeding. So it depends on the intensity of the reduction or reduced platelet count that lead to a specific complication, either it's hemorrhage from minor trauma or spontaneous bleeding or severe bleeding. So the thrombocytopenia, which is usually a result from decreased production of the platelet count, or sometimes the increased consumption of the platelet count, or both. acquired thrombocytopenia, in which the causes are platelet count being reduced. There's a reduction in the platelet count production, either due to the nutritional deficiencies, certain types of medications, thiazide, estrogen, quinines, or chemotherapy medications, chemo. There's also autoimmune disease and viral infections that could result in a reduction in the platelet count, aplastic anemia, or chronic renal failure. And these are the most common types of the thrombocytopenia due to the increased platelet consumption. Either it's HIT, which is heparin-induced thrombocytopenia, or the idiopathic thrombocytopenia purpura, or thrombotic thrombocytopenia purpura, or DIC, which is disseminated intravascular coagulation. The two most common ones are the HIT and the DIC. The other two that are autoimmune diseases. So the consumption coagulopathy, which is a DIC. So let's talk about the HIT before we get to the DIC. The heparin-induced thrombocytopenia, the HIT, which usually occurs in about 4% of individuals treated with unfractioned heparin. So patients who receive unfractioned heparin, especially the intravenous, the IV heparin, they tend to develop that, and it's only affects only 4% of the individuals or patients who receive the unfractioned heparin IV. And the incidence is usually much lower with the use of the low molecular weight heparin like Lovenox. So we have patients on heparin, others will be on lower molecular weight of heparin like Lovenox, like enoxaparin. So patients who receive the heparin, unfractioned heparin, they are at risk way more than patients who receive the enoxaparin, which is low molecular weight heparin. It's more common in people who undergo surgical procedures. It's an immune-mediated disease. And the adverse drug reaction caused by the IgG antibodies that will be attacking or against the heparin platelet factor 4 complex is going to hit the platelet count or cells and destroy them. However, the DIC which is a complex acquired disorder in which clotting and hemorrhage simultaneously occur. Patients will experience both clotting, blood clots, small tiny blood clots all over the vascular system, and hemorrhage or bleeding from the depletion of the platelet cells or count. Etiology or conditions associated with the DIC: malignancies, infections, pregnancy complications, severe trauma, liver disease, intravascular hemolysis, medical devices, like patients who, with a prosthetic devices or aortic balloon, and other conditions would be like hypoxia and low blood flow status, like arterial hypotension secondary to shock. So it's characterized by the widespread activation of coagulation resulting in formation of fibrin clots. Medium and small vessels will be affected throughout the body. The intravascular system will be filled with these tiny small blood clots. in which that this kind of magnitude of clotting will result in the consumption and depletion of the platelet cells and clotting factors. And then initially that will result in severe bleeding from that deficiency. So by activating the fibrinolytic system, which is plasmin, then the patient's FDP, fibrin degradation product, and the D dimers will increase. And these are the two indications or lab values when it's when they are elevated at high levels. They indicate the presence of blood clotting or a DIC. So because of the patient's clinical state, then the disorder has a high mortality rate. And the treatment is to remove the stimulus. And what are some of the clinical signs and symptoms that would demonstrate the presence of this DIC or an indication or manifestation of DIC, like bleeding from the venipuncture site, bleeding from the arterial line, petechiae or hematoma, symmetric cyanosis of the fingers or toes. These are all signs and clinical manifestations that would demonstrate a wide variability of the DIC disease.